Three, two, one. We are live now, sir.
Good evening, everyone. On behalf of the Asteria Division of Intas Pharmaceuticals, I extend my warm welcome to all the respected doctors and delegates who have joined us today. Asteria Division is proud to be the scientific partner in this ongoing academic webinar series on de-addiction. Today, we have the second webinar in this series centered on the highly relevant and evolving topic that is, where does Acamprosate stand today? A clinical efficacy perspective. And yes, we are privileged to have an esteemed panel of experts whose clinical experience will definitely add immense value to this webinar. Now, it's my privilege to introduce and invite our speaker and moderator for today's session, Dr. Siddharth Sood. Dr. Sood is a distinguished addiction psychiatrist, having completed his DM addiction psychiatry from AIMS, New Delhi, along with MD and DNB in psychiatry and MBBS from Maulana Azad Medical College. He is super specialist and consultant psychiatrist with strong expertise across addiction psychiatry, neuromodulation, and psychopharmacology. Dr. Sood is widely respected for his ability to bridge clinical psychiatry with modern neuroscience, bringing both scientific depth and practical insight into patient care. We are confident that under his leadership, today's discussion will be highly insightful, clinically relevant, and enriching for all of us. With this, I invite Dr. Siddharth Sood to kindly take over the session. Dr. Sood, please.
Thank you, Mr. Rahul. Thanks for the brief and warm welcome. First of all, I would like to welcome all our respective audience who have joined us on our Monday evening. And today, to begin with, if you can, the support team, please let me share my screen. To begin, just a second, I'm pressing some. I hope my screen is visible to everyone.
Yes, sir, it's
Yes.
visible.
So first of all, good evening to everyone who is joined. So today we'll be talking about a very interesting and unique topic about Acamprosate. And to begin, I would want to introduce my panel. With me is Dr. Pratik Rajput, who is who holds a dual specialization, having done both his MD and DMP in psychiatry. Welcome, Pratik. Along with new panelists, including Dr. Shruti Tagre, welcome, ma'am, and Dr. Sagar Karia, Dr. Mahesh Gigal, and Dr. Jitendra Biswa. Welcome, everyone, and I'll be looking forward to your perspectives. So, to begin with, Acamprosate. Last time we were talking about naltrexone, and naltrexone is a drug which we discussed was used in multiple indications across psychiatry and not just addiction. But Acamprosate, as we'll see, is a very, very, very unique drug. And to just begin with, if there is one drug which I have prescribed the most throughout my DM training at AIMS Delhi and even now in my own private practice, it is actually Acamprosate. And I feel the most comfort in prescribing this drug, and I'll be sharing why. I went on to include it in my cases also, which I'll be talking about. So just to begin with, this is a slide I really enjoy sharing every time. So this is basically the epidemiological data which we had from 2019 survey by the NDTTC team. And as we speak, the next survey is going on, so numbers would be updated. But very interesting is the numbers, like dependent users also is 2.9 crore, which is a very high number, 2.7% being the prevalence. And there is a very high treatment gap, even more than other respective psychiatric disorders for alcohol use disorder. And very interestingly, there is a very staggering divide in Indian alcohol use amongst men versus women. So what the survey went on to mention is that for every 17 men who are dependent, there is one female. But, and very interestingly, women display telescoping, which should always be remembered. Not getting into too much details, but simply it is a faster progression to severe dependence and severe medical comorbidities seen in women using substances, not only alcohol, but in general. So the central question today is, amidst the mixed trials and robust meta-analysis and so many other competing agents, where does a drug like Acamprosate stand in 2026? So whenever we speak, our idea is not only just experience-based, but in today's time to always talk about evidence. right? Because today's time we practice evidence-based medicine. So it is not very important what I am saying. It's not a very important what other respective psychiatrists or any other doctor is saying. It is important what the evidence is saying. And for a drug like Acamprosate, we have the highest level of evidence there. We have Cochrane reviews, which as you would know is the highest level. So we'll be getting onto that. So in brief, what we'll need to know is the neurobiological understanding. So very roughly, when we take alcohol, alcohol increases the GABA, which is the inhibitory neurotransmitter and its actions, and it reduces the glutamate at that level. So whenever alcohol is stopped or alcohol level reduces, there is a rebound hyperglutamatergic state, which makes hyperexcitability, and this is the reason why patients present with autonomic symptoms and eventually withdrawals also. So once alcohol is stopped, the GABA levels goes down and glutamate increases. There are many more things that happen, but this is a very rough overview of what we want to see. Then moving on to the mechanism of action of a drug like acamprosate. So it's a structural analog of GABA and an endogenous taurine. So its main mechanism of action is modulating NMDA receptors. In short, it modulates the glutamatergic neurotransmission, thereby helps to dampen the central nervous system hyperactivity, which is seen when alcohol is stopped, right? So in short, it helps to restore the GABA and glutamate balance, which is affected in alcohol use disorder. So very roughly, this is what we can say. With respect to pharmacokinetics, also there are some things we need to remember. First of all, the bioavailability is comparatively lesser and poor. So one of the reasons why such a higher dose is given. But very importantly, for this lecture and for the clinical practice, it is important to remember that the minimal hepatic metabolism is there, while excretion which occurs through kidney is the majority most important thing. So minimal hepatic metabolism enables very safe use in liver disease, right? In case of liver disease, normally we would be hesitant, would not want to use drugs like naltrexone or disulfiram. So acamprosate is a drug which is used in such cases, which we commonly see. Guidelines also mention the same. But because it is metabolized through and excreted through kidneys, some amount of dose adjustment is needed in cases of renal disorder. If the creatinine clearance is more than 50 milliliter per minute, it's the same dose. Dose needs to be adjusted when the creatinine clearance decreases. And in general, it is a good idea to get serum creatinine done whenever we are planning to prescribe this drug. And what makes this a more used drug is this safety in advanced alcoholic liver disease. So there is very minimal hepatic metabolism for acamprosate that happens. And it does not induce hepatotoxicity and does not also increase transaminitis. It is also safer in decompensated alcoholic disease and alcoholic cirrhosis. And it is safer with respect to drugs like naltrexone and disulfiram, which are otherwise used. So to remember is acamprosate is among the preferred pharmacotherapies for relapse prevention in patients with advanced liver disease because it undergoes minimum hepatic metabolism. So it's a very simple point, but becomes very important when we are prescribing. And as most of you know that alcohol is metabolized by liver and a lot of dysfunction in body is due to the liver disease, liver pathology by alcohol. So liver status is something we always need to keep in mind when we see a patient with alcohol use disorder. Now, just to compare and contrast, last time we talked about naltrexone and we compared naltrexone with acamprosate. And also to bring into notice is baclofen, which is comparatively a similar molecule because even like acamprosate, it is being used in patients with liver disease, even with patients with cirrhosis. But interesting point to remember is that at least for us in India, it is not an approved drug for alcohol use disorder, right? Acamprosate is approved, naltrexone is approved, disulfiram is approved. Baclofen is not approved for us. And it is not the first line treatment. Always remember that. It is being used very commonly as a off-label use because it is not currently approved. It is used a lot in other European nations also, but it is not approved. And always remember that there is not enough evidence for baclofen. The Cochrane review does not support it, hence it is not approved. Right? Whenever we have to talk, maybe with each other, maybe with patients, and even if it comes down to any legal thing, always remember it is the level of evidence, and Cochrane reviews backs up both acamprosate and naltrexone, which we will be seeing. There are many different drugs that are being used in treatment of alcohol use disorder once detoxification is done, like topiramate, like pregabalin, gabapentin. And even now, trials are also coming up, not from our country, from other countries for drugs like semaglutide. While all these drugs are there, topiramate is a drug which is very commonly being used with many advantages. It is not a first line. The Cochrane review, the level of evidence does not back it up. So until unless it is patient's choice or some other reason, we should always stick to first line drugs until unless there is some other clinical reason or patient choice which makes us choose some other drug, right? So first line drugs are always acamprosate or naltrexone, while baclofen is a drug which is being increasingly used and possibly also being used in those with severe liver disease, those who are planned for liver transplant and so on. So very interested for acamprosate. Last time we were discussing when we should be starting naltrexone, right? So while evidence for naltrexone also says that should ideally be started once withdrawal management is done, but for us in Indian settings, many times it happens that patient does not follow up. Same is the case with acamprosate. I went through a lot of evidence to look for this thing, but most of the evidence suggests that it should be started after acute withdrawal management is done, right? Although as a good clinical practice, while I was doing my DM, we did used to start it while we were prescribing tapered dose of benzodiazepines in OPD settings, purely because we were always not very sure if we'll be able to retain the patient or if patient is going to come back or not. So we were using it, and because of its GABAergic action, we were also able to sometimes reduce the diazepam or lorazepam dose that we were planning to give. And because of its liver safety, many times when we were not even having the liver function test, patient is coming for the first time in OPD. As a good practice, along with benzodiazepines and thiamine, we would also start acamprosate. The only caveat for it being that it has to be given 3 times a day. And there are some differences in naltrexone and acamprosate, right? And we'll be seeing where we would select acamprosate. So when we talk about trials, when we talk about evidence, what we need to know is what are the most important parameters, what are the clinical outcomes which actually matter. So when we're talking about a drug like acamprosate, we talk more about abstinence, complete abstinence, rather than reducing the amount of alcohol. So we use parameters like time to first drink, percentage of heavy drinking days, and craving scores, multiple, which are used mostly for purpose of research, not very clinically relevant in day-to-day clinical practice. And what we need to remember here is that both these drugs differ, naltrexone and acamprosate, with respect to what clinical outcome is there. Simply, what we can understand very roughly is that naltrexone is a drug which is being used to reduce the heavy drinking, because when you see patients with alcohol use disorder in your OPDs, many a times patients are not willing for complete abstinence, right? For one reason or other. And before we get into debate about that, evidence does not suggest that controlled drinking is something that should be tried. But again, evidence is not something which is practically applicable in OPDs always in this case. So patients would often argue, they would say that they are going to drink on some occasion, other occasion, right? They do not plan to be completely abstinent. In those cases, we tend to use naltrexone, as to reduce the number of drinking days, reduce the amount of alcohol being used. And in such cases, the goal of treatment is not to achieve complete abstinence. Remember, when we are taking a case in addiction psychiatry, when we talk about the final treatment plan, in that before we tell what medications or what psychotherapy, we always say what is the goal of treatment, right? Like we talk about opioids, the goal is to reduce, like completely stop illicit opioids. But in case of alcohol, the goal might not be complete abstinence. It might be reducing the alcohol amount. And roughly many books or journals do talk about, harm reduction from naltrexone. That is not a completely correct term. with respect to alcohol, because the only evidence-based harm reduction in alcohol use disorder is don't drink and drive. It's not don't drink at all and then drive. It's don't drink and drive. You are allowed to drink, but should not be driving, right? That is the only evidence-based, evidence-backed harm reduction in alcohol use disorder. But we do talk a lot about naltrexone as a harm reduction in alcohol. It is not completely correct. So getting back to the point with respect to acamprosate, our aim is to plan for complete abstinence, and we use these parameters, which is the continuous abstinence, time to first drink in days, number of heavy drinking days, which we use. Now, having understood these things, let's look at trials. The first trial, as long as 1996. So acamprosate was compared to placebo with respect to abstinence at the end of study. So clearly it was significantly better than placebo in in improving the number of days of abstinence. And this was in 96. Another trial from other place showed the same. But what is interesting for us to remember is this, the combined study from 2006, which went on to show that it is not better than placebo, and naltrexone is actually the superior drug. So always remember the combined study from 2006, which was the largest US trial, failed to show any efficacy for acamprosate, and that is a very landmark trial which we should be knowing about, and it failed to show the superiority of acamprosate. But still, here 20 years later, we're sitting and talking about acamprosate at first line. That is because of this Cochrane review. So Cochrane review has demonstrated very good evidence, and it makes it the first line of drug. With respect to return to any drinking, it is good. Abstinence difference also, the mean difference is more. So it shows statistically significant effects. And just to get into a bit more into trials, the last number I want to see, NNT is 12. It's modest, but still significant, right? Now, with respect to heavy drinking, naltrexone is better. But with respect to the goal being complete abstinence, acamprosate is better. So acamprosate demonstrates highest efficacy when our goal is complete abstinence. And why? Because of its mechanism of action. No, it tends to act somewhat like alcohol. Again, alcohol has multiple mechanism of actions. One of them being its effect on both glutamate and GABA, and acamprosate is displaying the same. Right? Although interestingly, most of the evidence is talking about using acamprosate after acute withdrawal management has been done. Now, as I was talking, effect on heavy drinking is not as much as naltrexone and not significant. So if the goal is to reduce alcohol or to go for controlled drinking, it is not the drug that should be preferred. And the number needed for treatment is 12. So 12 patients will give you one complete abstinence. So it is a very good number actually. Just in brief about its safety and tolerability, it is generally well tolerated, except many patients do report about having bloating in the beginning, right? Some gastrointestinal diseffects, diarrhea also, but it is generally very safe with respect to hepatotoxicity and with respect to dropout rates. Because remember, when we talk in addiction psychiatry, we talk about retention of patients in treatment. There may be retention with respect to opioid use disorder patients. There is a retention with respect to alcohol also. So we would talk a lot about dropout, as our idea is to keep the patient in retention, keep the patient in treatment, so that eventually you are able to help them with medications, with therapy, with some other intervention maybe, but keep them in retention, keep them in follow-up. So dropout rates become a very important parameter. And it was equivalent to placebo also. And interestingly, it has not shown significant interaction with benzodiazepines or alcohol also, while we do talk about its use in once acute withdrawal management has been done. And this is the same slide which we also talked about last time, comparing acamprosate and naltrexone head to head. Very roughly, naltrexone is better with respect to cue-induced craving, while with respect to otherwise relief craving, acamprosate might be the better drug. And very interestingly, in the beginning of the this presentation, I was talking about men versus women with respect to alcohol use disorder. Although the number of women, at least in our country, who are using alcohol socially, who are using in a harmful pattern or are dependent, are far less than men. But it is very important for us to understand about the treatment also, as it differs in women. Efficacy is comparable between men and women, but with respect to pregnancy and lactation, we need to understand that animal studies do suggest potential fetal risk, while robust human data is currently limited. So ideally, the treatment of choice in pregnancy is behavior therapies and acute withdrawal management. Drugs like acamprosate should be avoided until unless the benefits are far more than harms. Other drugs, similarly, naltrexone is what we talked about, should be avoided. Disulfiram should be avoided. Just to with this, all this theoretical knowledge till now, just like last time, I'll be sharing about some clinical vignettes to highlight about acamprosate use. Some of the cases that I've seen over my MD and DM. So, the ideal candidate, case number 1, a patient, 52-year-old gentleman with severe AUD, recently discharged after 7 days of acute withdrawal management and is abstinent for 7 days and reports intense anxiety, underlying tension driving his urge, and AST-LT, as we can see, is increased. And most importantly, perhaps in this whole slide, is the last line written. The goal is absolute sobriety. And these are not medical terms. This is what the patient proved. So yeah. So straightforward case, straightforward treatment, acamprosate, right? So second, 35-year-old female who binge drinks 4 times a week, refuses to get admitted and wants to cut back to 1 drink, right? Her liver functions are normal and she struggles with intense urges when walking past bars, and this in medical terms would be cue-induced craving. So here also, the most important term is patient's own goal, which is to cut back rather than complete abstinence. So naltrexone is preferred. Third, geriatric patients. 68-year-old gentleman recently abstinent for alcohol, known case of diabetes and interestingly kidney disease. Creatinine clearance is reduced. So acamprosate can be given, but dose should be adjusted according to creatinine clearance, that as we previously discussed. Case 4, decompensated cirrhosis. In such a case, patient was a 45-year-old gentleman who was actually admitted in gastroenterology ward with ascites and jaundice, diagnosed with alcoholic cirrhosis, abstinent for 14 days through the time patient was in medical ward in hospital. So we also again tried acamprosate. While in such cases, we start thinking of baclofen also. And case number 5, very important practically, the non-compliant patient. So Manuel Libra, 28-year-old, was managed, acute withdrawal management done, poor health literacy and forgets to take medications. So this becomes the biggest challenge with respect to acamprosate. While it's a very good drug to give, very few side effects, but it has to be taken 3 times a day, 6 pills, and most of the patients we see are above 60 kgs. So 2 becomes very difficult to take because patients, and understandably so, are obviously busy with other aspects of life. So compliance becomes somehow poor with respect to acamprosate, and this is what I have seen practically also. But just to add, not a clinical vignette which I have added here, but my own experience for over 15 medical doctors, mostly specialists and some super specialists also, presenting with alcohol use disorder in a dependent pattern. And I tried using naltrexone in them, or naltrexone previously used, with not good outcomes. And I initially used to think that being doctors, they must be more busy, and they were. But acamprosate, they started taking in, outcomes were better. Almost 12 of those 15 are abstinent as of today also. So I don't know. I tried to search for evidence also that backs it up. I did not find any such evidence as such that it is better for maybe professionals or any such thing, but my own experience. Again, that is experience, not evidence-based. And something to share about, which was my own DM research thesis. It was about using RTMS, theta burst stimulation, in those with alcohol use disorder. While I'm talking about acamprosate here, why? Because patients were given treatment as usual, because it would be absolutely unethical and would never get approved by the respective ethics committee of any institute, especially AIMS, if I would not have given the treatment as usual. So there were two groups, one which was sham, one which was active. Both received treatment as usual, and the drug selected was actually acamprosate. So I had very good experience with acamprosate even during my DM research also. This slide, which is somehow controversial, and I would say that it is completely the above words that are written. These are experimental and investigational uses only, right? The term that we use, that it is for training purposes and information purposes only, not to be used until unless there are strong evidence. So tinnitus investigated because of its glutamatergic modulation, inconsistent evidence. Fragile X syndrome, again, very few pilot studies. Other neuropsychiatric disorders, very few exploratory studies. Other substance use disorders, evidence does not support. So no off-label indication currently. So currently, acamprosate is a drug specifically for alcohol use disorder only, and perhaps every other drug like naltrexone has multiple uses. Even a drug like disulfiram is used very commonly in cocaine use disorder, while that is also off-label, but it has use. So acamprosate becomes a drug with only one approved use and almost no off-label use until if my panelists tell me, or my respective panelists tell me any other use that they have tried. So from my side to conclude, where does acamprosate stand in 2026? So remember, it is not the best treatment, because there is never a best treatment. It always depends on the patient's profile. It is an essential targeted pharmacological tool which has proven abstinence, unmatched hepatic profile, with limitations that it does not reduce heavy drinking, right? And it is something which is a first line backed by Cochrane review. There is very good evidence for this. So always remember, this is why we should be using it. And just to conclude, these are the take home messages, right? These are the points that I've discussed, nothing special in this. But what is interesting and new here this time is regarding feedback and discussion. Last time I did receive feedback from a lot of the people who joined, and I'm very thankful for that. That has helped me to maybe improve this presentation somewhat. So what I would request from everybody who's attending is to please use this QR code. It will give you an anonymous Google form to fill. There are a few questions on what you like, what you did not like, what can be improved, and that would be very helpful for us, so we can improve and maybe include more things or better way of discussing. Thank you. Now I would ask my respective panelists to please give their respective opinions, their feedback, starting with Dr. Pratik Rajput.
Thank you, Dr. Siddharth, for an excellent presentation. Am I visible to everyone? Yeah. So, as you said, there is one small study in which there were three adults with Fragile X syndrome and comorbid pervasive developmental disorder, and they were given acamprosate, and it was found that they showed improvement in social behavior and communication. As far as I know, there is no drug which is currently approved for improvement of social communication in autism spectrum disorder. So this is an excellent perspective. The theory being that peripheral glutamate has been shown to be increased in youth and adults with autism compared with controls. Also, in post-mortem studies, NMDA receptor 1 protein levels are increased in cerebellar tissues of people with autism. Also, GABA A receptor subunits are underexpressed compared to controls. So, as you explained about the mechanism of action of acamprosate, it can be used, but yeah, the evidence is still preliminary, and more research is warranted in this field. Also, continuing with the cytotoxicity theory of tinnitus pathophysiology, in a double-blind study, research found a high index of success in the relief of tinnitus using Uh, in another open label trial, Acamprosate demonstrated a significant positive effect in decreasing anxiety for most patients. Uh, the patients are mixed generalized anxiety disorder, panic disorder, etc. Also, in another open label trial with pathological gambling, results suggest that Acamprosate might be effective. But yeah, the level of evidence is not high. So these are some other indications where a compressor can be used, and future will tell what happens. That will be all from my side.
Any other additions, Dr. Pratik, that you would want to add?
Uh, I would like to ask a question from you, but I will ask it in the head after
Yeah,
the
yeah,
audience have completed
yeah. Let's
the series of
like take
questions.
yeah, like feedback and inputs from our respective panelists first.
Yeah, yeah.
Thank you, Dr. Pratik. Dr. Sagar, if you would, sir, please unmute yourself and please add to the ongoing discussion and your own feedback and clinical experience, sir.
Yeah, so as we have discussed that acamprosate definitely comes as the first line of uh, drug for controlling the craving of alcohol. And till in my this 13-14 years of practice, there is no other indication where I would like to use acamprosate. Otherwise, I like to use many molecules off-labelly also. But this is the only molecule where still we have not been able to find any off-label indication. So it is purely for alcohol. Main disadvantage of using this acamprosate is the dosing 3 times a day, which we had addressed in our talk also. So that is the main thing. Baki, as we all know, it's the first line of management. It's the safest drug, and as you also said, and we also do the same. We start right from the day one. We don't wait for the patient to go into the withdrawal or anything. We start from day one. The same thing.
No, interestingly, sir, that is most, I think India may that is what we are doing, but I tried to find evidence for this, but somehow Western trials or Western evidence is not talking about this, despite its mechanism of action actually supporting its use during withdrawal management itself. And
Yes.
many times we are hesitant because the amount of diazepam that or lorazepam to be given becomes very high, and patients are not agreeing to get admitted whatsoever. And
See, it's I think much better to give acamprosate rather than alcohol in ICU. There are some hospitals who provide alcohol in ICU patients, so I think acamprosate is better. It is that's why called as artificial alcohol.
artificial. Thank you, sir. One more thing, if I may ask you, though somebody has asked that we are giving thrice a day. Like, what are the strategies you found which are effective to improve the adherence in real world settings?
Yeah. So what I have done if the patient is unable to take 3 times a day, what I give is 102 or 201. So
Okay.
one in morning and two at night. Now again, I don't know why this habit of giving 3 times a day has come. Though the half life, if you see, it's very long. So we don't understand the logic of giving 3 times a day in this molecule, despite being long half life.
So again, the logic being that something is again better than nothing,
Yeah.
and it's better to take acamprosate than to supplement benzodiazepines with alcohol, which many patients actually do. So also very interesting question which is out there. Would you say any experience like with respect to specifically somebody has asked about cardiomyopathy?
Safest to use. The acamprosate is the safest molecule. Means we can use it in renal failure also, hepatic failure also, and cardiac failure also. But only thing is that in cardiac failure we might not use. He might be in ICU. But yes, with cardiomyopathy it is safe to use. There is no interaction or any contraindication for this.
Yes, sir. Interestingly, I also wanted to find evidence. So alcohol-induced cardiomyopathy is there, and if patient is like able to take not in SU, so we actually do use acamprosate only. So
Yeah.
who's Dr. Subhash was asked this question. Thanks for asking both these wonderful questions.
What
Any
is our this thing saying is कि alcohol is more hepatotoxic, more cardiotoxic than acamprosate. So safer to use acamprosate and diazepam rather than alcohol. So we go with that principle.
okay, sir. That's a, more pragmatic and real world than maybe what the trials show.
Yes.
Any other point you would like to add, sir?
We'll ask Dr. Biswal sir and all.
Dr. Vishwal, if you can, good evening, sir, if you can unmute.
Yeah. Can you hear me?
Yes, sir.
Yes.
Yeah. So the relatively what happens in acamprosate, the oral bioavailability is very low.
It usually falls below 25. Some studies says also 20%, 15%. That's why they give multiple dose because that is very low. So less amount reaches into the blood, and it is also getting affected when the absorption also get affected by food. So this is the reason they give 3 times a daily. So in practice, that usually affects many people who are like you have discussed a case of manual labor. Like in that case, taking 3 times daily is really a difficult. Like he will busy in work. Like those who are going office also sometimes they find difficulty. So in India, like as I mentioned, you have mentioned also we are giving twice daily. We are giving two in morning or sometimes two in night also. So it also helps. So exact the same dose as per the like weight 60 kg we are taking like give like two tablet or one tablet. See there is a not a steep cut off. Suppose someone is 60 kg, suddenly you will give 666 TID. So someone is 59, you will give 333 TID. That is the actually absolutely there is no logic there. Suddenly 1 kg does it makes a huge difference. So that dose is not visible. That's why our dose, what we are doing like 102 also works, 201 also works. So like that in between dose is there. So if you are possible one tablet in daytime, if he can take, that is definitely going to maintain such a like complete abstinence. Definitely you have discussed about that Cochrane review has given extensive research, huge data. Cochrane has usually took the data nearly 7,000. That data is very strong, which suggests that naltrexone and acamprosate, when we're using, naltrexone is definitely reducing craving very fast and it is very effective also. Acamprosate is also reducing that, but in case of complete abstinence, its data is strong. Like there are few studies who have used acamprosate, they found that complete abstinence is much better in acamprosate. That study favored that Cochrane review. That's why that goes towards that. But these molecules are like head on head. But naltrexone has one advantage and disadvantage. Like someone is tolerating, suppose naltrexone, both can use in detoxification phase also. In Western data, it is very, that's not a problem. But in particularly, if a patient is not hepatotoxic, not in a serious liver injury, in that case, single dose works, we give that molecule naltrexone quite commonly. Like it is compliance is very good. Family member sometimes when he goes for work, we'll give a morning one tablet and go. No problem. Next day morning, we'll give another tablet, he will go. So that he will not worry, he's taking more in daytime or evening. That is not bothering. Many people usually consume in evening. So when they came from the work, they consume alcohol in Indian practice. So that cases we sometimes fail because they will consume, they will not take evening dose of acamprosate. We fail. So motivation and therapy, they always play a background role and the major role in managing de-addiction. And we have also there are major evidence in JAMA also. If you see, we have discussed many strong evidence 2023 systemic review also, that has also given strong evidence support of this molecule also. So evidence is there, clinical experience is there. I see it is a safe molecule. Side effects are there with each and every molecule. So major like thing what research like currently we are going with that neurostimulation. You have done your own research also. Dr. Sud has done his neurostimulation. So in that case, it is like we are not certain of anything. We don't know whether RTMS can replace anything, TDCS can replace anything. So we are not certain. Anytime when I was trying that TDCS and doing fMRI, so then I see definitely it has given some result. But that result is like near positive. Like we are trying something and we're getting something positive, but we are not 100% sure. Like the evidence is very strong for other, but for if there is a patient, he is not taking medicine, he is not interested in medicine, I cannot say 100% you go for RTMS therapy and you will maintain abstinence forever. It's very difficult. So that I want to, if you can highlight on your research part, which I could not able to hear from you. You just mentioned that that molecule acamprosate was given there. Like it was given because it was a placebo trial. So when you gave acamprosate, those who failed or what happened? If you
See,
highlight
so
that,
the idea was being done at an institute like AIMS. The ethics committee would never approve a monotherapy at all, and that would be absolutely wrong on my part because there is no data to back up that. So two groups were there, both were given RTM, active RTMS or sham RTMS, and treatment as usual continued, which included acamprosate for both groups and thiamine for both groups.
okay. So that was there on the background entire time.
Yeah.
So after
So-
that, what was the result?
So Acamprosate was started once RTMS was finished, and we were able to comment on the alcohol use, not the craving scores. Sorry, other way around. Why the craving scores decreased more at that point of time? No anti-craving or no benzodiazepine were given to either of the group. It was purely RTMS. We kept the patients in ward during that time in a controlled environment. Once we were to discharge the patients, a treatment as usual for both the groups were given, and the idea was to see how long this effect of RTMS is going to persist, given that now the patients are going back to real world and are receiving the same behavior therapy and same treatment as usual, the same pharmacotherapy. So how long is RTMS once given going to persist? So that was seen.
That's good.
And eventually, as you said, the cost, at least right now, does not justify you being done in government sector, being a research. It was like free for the patients, but we cannot otherwise justify the cost, and it does not have the evidence that to back it up as a monotherapy at all right now. That is not something which we can actually talk.
That's
Thank
correct.
you, sir, for your inputs.
Yeah,
Dr. Shruti, ma'am, if you can please unmute yourself and give your feedback.
Yeah.
Yeah.
Thank you for an excellent presentation, Dr. Siddharth. Yes, the same practical aspects as you mentioned. But I would like to mention one study which you mentioned about the US study where Acamprosate was found to be non-inferior. So I think there's one more study which had actually combined naltrexone with Acamprosate, and they had compared the addition of Acamprosate versus naltrexone alone. So there was not any significant effect seen there. In real life aspects, have you tried combining these two ever, like day-to-day basis? In severe cases where patient has relapsed multiple times, it's become very severe. So I would like to know your insights about that.
So, Dr. Shruti, with respect to that, what you're
Hmm.
saying is that that particular study, combined study, did not show efficacy of combination of both
Yes.
versus mono.
Yes, yes.
So in real world, I have personally not tried combining them both. We used to have a habit of choosing either naltrexone or acamprosate plus disulfiram plus behavior therapy. So idea was
Yes.
disulfiram with either of these plus behavior therapy and not
Yes.
combining both of them. So we have used to avoid that because of this evidence that combining is not very beneficial, and it becomes a bit when acamprosate like drug is being given, it becomes a bit difficult because the number of pills
Yeah,
increase.
yes, yes,
So
yes.
I have not
Yes.
tried that much. If
Yes,
any
yes.
other panelists would share that
The
their own clinical
polypharmacy is
experience.
my right hand, no? So I have used, sir. So polypharmacy is my right hand. So we have not combined two, we have combined four molecules together.
Oh,
So
oh,
Acamprosate 222, topiramate
oh,
100 milligram 3 times a day, baclofen 30 BD, and disulfiram 500 milligram. So we can combine all these four molecules. If the patient is really very much, I said, no, so-called alcoholic, then we can use definitely. But these are some rare instances. But routinely, I combine two anti-cravings. So topiramate and baclofen, or acamprosate and baclofen is routinely.
So what about
Usually,
SSRIs?
SSRI only if the patient is having depression, then I will use. Otherwise, for anti-craving, I have not used, but only for depression. Here we are discussing about naltrexone. So just one simple question I would like to ask also, and I would like to comment also. Naltrexone is not like your acamprosate or baclofen, which will cause the strong anti-craving effect. What is the main use of naltrexone is it has to be actually taken 1 hour, 1.5 hour prior the drinking. So if you give in the morning and the patient is going to drink in the evening, it's not going to cause that much of effect for the drinking pattern. He will continue drinking 3 packs or 3 quarters, whatever he drinks. So the ideal is it should be given 1 hour prior. So is it right, Dr. Siddharth? And what I say the relatives कि वो नहीं घर पे पीता है लेकिन वो स्टॉप नहीं करता है, तो मैं बताऊँ पहले पैक में उसके अंदर नाइट्रोजन डाल दो ताकि एक पैक के बाद ऊपर जाएगा ही नहीं, वो ऐसा है. So what do you say on these things? Like it has to be given 1 hour prior, no?
Sir, like it is being is used as a so-called harm reduction technique, what you're saying, yes. But with respect to naltrexone, I would say that it is like having very strong action. So generally we educate the patient to take it daily. Otherwise, patients should, not use it. Although what you're saying is something which patients do actually try and makes a lot of sense because the aim here is now to reduce heavy drinking. not to stop them from drinking completely. So that is something which we actually do tell the patients, but actually we don't want them to think that it is a SOS medications, because that is what the patients conclude from this discussion always. That
Yeah,
this is
for
SOS.
heavy drinking,
Yeah.
definitely we give twice a day. That is true. But some people drink only in occasions, but they
Yeah.
can't control. So that time we give 1 hour before
Yeah.
in the parties if they go. Yes.
Definitely, sir.
Dr. Siddharth,
Yeah, Dr. Ramesh, please.
yes, I found कि many young patient has GI side effect with naltrexone more, and with Acamprosate there are few GI side effects. So in your practice, what is your opinion for both molecule and GI side effect?
So with respect, see, first of all, with respect to alcohol, it itself causes a lot of GI side effects. So I'm never really sure if what patient is reporting is due to our drugs or due to alcohol, current use or past use, which has possibly damaged the GI lining. So with respect to acamprosate, patients do report some bloating in the beginning, which over time they get used to. Naltrexone, somehow some patients do find it very difficult to use because of this GI distress that I've also seen more.
In starting first week, especially for young patient, nausea and vomiting.
Yeah, that is always one. Nausea, vomiting, those things are for naltrexone more.
Yes.
I've seen that, but eventually tolerance just develop. That is what we try to tell patients also.
Okay.
Dr. Siddharth,
Any other thing that you would like to add, Dr. May? Anything
No,
from your
no.
practice? And again, Dr. Shruti, I think you were also adding something before.
No. I think I just also wanted to explore like GLP-1 agonists that you mentioned. That of course they
Yeah,
are also.
don't.
About that,
Not for alcohol.
yeah.
Not
Yeah.
directly.
Yes. Because you mentioned the case profile with the patient with DM and uncontrolled diabetes, and his KFTs were a bit declining. So, like choice of medication in that case, maybe can we consider like in such a patient? I don't think like of course like the first line of management, but something like an add-on because it will have like bimodal effects. It will have dual effects. Sorry for my language. It will also help us control the diabetes as well as it will also work with the reward pathway as well.
I think what again I would then now request the panelists also to add. But as of now, I feel that gastroenterologists or the endocrinologists right now would be the better choice. I don't think that's a drug that is currently are under control as of now. While I think it should come and it might come in times to come. For us Indians
Hmm.
also, I think US, if you go see, there even psychiatrists are talking about it all and themselves also using. I think this is
Hmm.
something like thyroxine. So most of us do use thyroxine now. I use it a lot for
Yes.
augmenting in depression. I
Yes.
don't take permission or referral from endocrinologist. So I
Yes.
think it is one of the maybe something which will happen. Again, this is very interesting. Thanks for raising this. Our respective panelists, if they can add their point of view regarding this very point.
Regarding thyroxine in depression,
GLP-1 agonist, sir.
GLP-1 agonist in
see,
alcohol.
any
Yes, in substance use, yes.
see any molecule which is coming to the market and it is booming for some reason, they try to market it everywhere. So that's a
Hmm.
marketing strategy. Suppose they know that the huge chunk are there in addiction, so we can try there because it is helping to reduce craving for food. It will reduce the craving for that substance.
Hmm.
Unless we are practicing medically and the evidence is not strong and such a molecule with high cost, we will not, to some extent, society will also not allow, our ethics will not allow to prescribe to patients. So experimental use is there when there is a research, when there is a free of cost, when there is a insurance, then only we supposed to try. That is supposed
Hmm.
to be there, we supposed to be the
Okay.
ethically bound. So
Okay.
that is what I believe. And as Saga Sarah has mentioned something like baclofen, naltrexone. If you give 1 to 2 hours before, like those who are heavy drinking, many clinicians practice that. Those who are doing heavy drinking, going for party, they know that this is a weekend, Saturday evening he will go for a drink. He does not go regularly, only Saturday evening. They can take when they are going there, they can take if self-motivated, then their alcohol consumption will reduce. And those who are heavy drinking, family member can give them twice a day. So, but regular routine practice for every practitioner, mostly once in a morning is the common practice which is used. And that's why you have mentioned like they can use twice daily. So that time they can shift to another dose if they require 25 also they can try that time, 50 also they can try. Only situationally, certain group of patients required 1 to 2 hours before to get maximum like effect of that medication so that the consumption will not go to a harmful use, limited use of alcohol. That's a good evidence also there. Like some case studies are there. I have not gone through the entire literature, but some people also reported
Yeah.
that same to our hospital also.
Okay. Uh, Thank you, sir, for this suggestion. Dr. Sagar, if I would like, I want to ask you the same thing. Like keeping these things aside, like not considering the cost and other things. What is your opinion regarding GLP-1 agonists in alcohol use disorder?
Currently, I am not going to try using it because it
Yeah.
is new in market, and there are various studies which have said that they are known to induce a lot of psychiatric illness, like suicidality has been increased, depression has been increased. So see, इधर अल्कोहल से वो नहीं मरेगा लेकिन सुसाइड से मर जाएगा. We see that is the stress for us. So till we get as a surety that yes, it can be used or it has some less side effects, we would avoid using such therapy. But yeah, research has said they can be used. Not only Ozempic, but there are now oral GLP-1 agonists, which are many in the market. So again, the cost will never be the contraindication for using the oral tablets. But we wait and see. Rather than disulfiram is our Brahmastra, उसको डराना है तो ब्रह्मास्त्र से डराएंगे ना. Why with GLP-1?
Definitely, sir. Pratik, if you would like to add something.
Yeah, I would like to ask you one question. I'm interested in psychopharmacology. What is the active moiety in acamprosate?
It's basically inhibitory amino acid taurine only, which has similar structure.
No, actually, I have searched some articles, and it says that calcium is the active moiety in acamprosate. So we need to uh, uh, tell it that acamprosate calcium. Calcium is the active moiety, and N-acetyl homotaurinate is biologically inactive.
Okay. So you are saying that the action that is coming on the various NMDA receptors.
Yeah, calcium is the active moiety in acamprosate, and N-acetyl homotaurinate is biologically inactive. Some research has said that. I can share it later.
Okay. So
What
we'll
is
go
your
through that
opinion?
and see, I will go through it, but what I have been following the ASM textbook and the most interesting, importantly, the Stahl's psychopharmacology. So they have gone on to mention about taurine and its action and on the various NMDA receptors. So regarding calcium, definitely you raise this point. I'll definitely get back to you in the audience next time if that is the case, because Stahl's has gone on to mention.
No, it should be taurine only. Otherwise, we would have used calcium carbonate as a anti-craving agent rather than acamprosate. So it is
Yeah,
taurine only, definitely.
yeah, that was
It is
my doubt.
definitely taurine.
If that,
Yeah.
yeah, that was my doubt
Yeah,
because some of
that's
the
a very
research
valid
has said.
question. Yeah, that question. When I was there, Dr. Shukla, you may know, he's working as a now he's a faculty in Nimans. He was also presenting his seminar. The person, there is a scientist, I forgot his name, who has done that research initially. And when he changed that calcium to magnesium, he saw the effect is not there. That's why you asked that question. I thought you have gone through that paper. So when he changed that calcium and replaced with magnesium, he could not able to see that effect. That's why that paper was highly around 2014 somehow that paper was there.
Yeah.
That was a highly like lot of people have gone through the research why it is happened. So he said that what I was believing initially, it is not the calcium, but now I believe that it is because of the calcium. Like the same question, other calcium molecule, does they work or not? So that paper has not answered by any other research. Not nothing was supported that. So still, I never got an answer. But his study is there. Still, that paper is there. He said that when I replaced with magnesium, I could not able to establish the efficacy which I was getting with the molecule previously with calcium. That I remember. You can go through that. Some people try sodium acamprosate also. Much less efficacy also. That time also research also come on that. Sodium acamprosate they have tried, magnesium acamprosate tried. Could not able to establish
So
that.
what we have in market is acamprosate calcium.
calcium.
Yes.
Calcium.
What I, sir, think on this is line that it's like same your sodium valproate and magnesium valproate, where sodium valproate is still available and working well, but magnesium not. I think it is something related to, I think, the absorption of the molecule. So that's why the calcium is helpful, and that's why magnesium taurate did not work well. So it should be in that way, I think so.
Yeah, because many research did not follow that. Whatever he has said in his one paper, no one has followed.
Yeah.
Okay.
Yeah, and as an MS, Charles has gone on to mention about taurine and glutamate receptors. So also the panelist of Dr. Tarun has asked about guidelines for continued treatment and how long do you prescribe and what are the factors for stopping the drug. It's a very practical question, I think, which patients, I think that is the first question patients always ask ki dawai kab band hogi. Like how
So minimum 1 year. One
Yeah.
year of abstinence. So minimum 1 year till he is abstinent, and then we ask the patient, अभी आपको क्या लगता है, confidence आ गया है, you would like to stop? He says no, मैं तो ये लेगा तो अच्छा है. So it goes on, but minimum 1 year, and sometimes lifetime also.
That is what we also used to feel, that it is the goals of the treatment rather than, like, to begin with, we don't want to scare the patients that it may be longer, but this is what we used to say, minimum this much. And then let's see how you are able to do and get back. Any other different opinion from any respective panelists, Pratik or anybody?
Yeah.
Pratik?
So, actually, sorry, I have to go. There is one patient is waiting, so I'll go. So
Thank you, sir.
Thank you.
Dr.
Thank you for inviting.
Thank you, sir.
Thank you. Have a
Thank
good
you so much, sir. Yes.
Yeah,
Dr. Shruti, if your opinion on this, like, I think you must also be encountering, and like, how do you, like, what is your answer?
Yes, of course. Patient's decision, yes, of course, when patient feels confident enough to maintain abstinence on his own. Of course, evaluating the psychosocial factors as well, speaking with the family if there were any previous factors which have now come into play, like looking at the employment status, looking at the social circle where he hangs out, and how has it been in the past previous year when the patient was on medication. And yes, ensuring that he continues the abstinence. So yes, basically 1 year when he is abstinent from alcohol, and patient's voluntary decision to maybe cut down on the medication and stop medications, and then assessing the family and assessing all these factors, and then making an informed decision with the family and the patient, of course.
So it is very interesting that as a, just to see analogy. So diabetes is a chronic disorder like alcohol use disorder. So in that, if suppose you are taking insulin, so you will not be talking about stopping it because for whatever reason the body is either not able to make or the receptors are not responding to insulin. So duration is not talked about because the underlying pathology cannot be cured. So when we talk about addiction, we cannot cure the underlying pathology. So why should we be so worried about the stopping date? Like again, with respect to antihypertensives, there's no date for stopping in most of the patients, except that yes, maybe lifelong, and it is actually lifelong. Similarly in diabetes and similarly in other chronic illnesses and substance use disorder being chronic illness in which we cannot treat the underlying cause, which may be faulty brain receptors, circuits, or whatever you believe in. So that is what I've always felt. Although, yeah, patients are not going to divert metformin, they're not going to misuse insulin and sell it to others or any such shenanigans. I understand that. That's always a response we get from other respective doctors. But this is something which I always think about, that why are we in psychiatry and even in more in addiction psychiatry so scared and worried of this thing? And like, if you have to take, you have to take. Like in diabetes, in hypertension, in nicotine, in alcohol. I don't know. And again, very interesting, another question by Dr. Prakhar Sharma. What type of patients benefit most from acamprosate? First time abstinence seekers, chronic relapsers, or those with high levels, and how do you identify? So if any panel member wants to please discuss or answer this.
What I suggest is all types of all these three types will respond to acamprosate if he has to respond. If he does not have to respond, he will not respond. Anyone will not respond.
So basically, when we talk about when we studies, trials, always remember they are done in very controlled environment and not in real world. Always remember. So in real world, factors are different, as simple as whether or not patient is willing to take our medication 3 times a day. As simple as wanting to take medication once, right? As simple as wanting to be abstinent or so-called controlled drinking. They become far more important than what is seen in very tightly controlled. To be honest, when we even do our research, we select patients very meticulously, very strict inclusion, very strict exclusion. So is with almost all studies. But if you go on to see pragmatic trials, they do talk about this thing that we cannot so tightly regulate everything in real world. So that is something which has to be taken with a pinch of salt. That yes, while evidence level is always important, but practically what is best for the patient, that is the answer. In more developed countries, maybe patients themselves get to say. In our country, maybe not
Also,
so
we
much.
have many people who have 2 or 3 substances together. So where
Yeah,
it is going to help? No? So that is also one of the
yeah,
factors.
yeah, definitely. And a drug like naltrexone, which is actually answer for everything, cannabis,
Hmm.
opioids,
Yes.
Yes.
smoking, alcohol, behavior addiction. So as opposed to acamprosate, which is specific for maybe alcohol.
Yes.
So let's see if
Uh,
there
the
are any.
ground reality, the ground
Mhm.
reality is harsh. I practice in Chhattisgarh. It is the
Yeah.
number one state as per the ILM study in alcohol
Mhm.
use disorder. And frankly speaking, 90% of patients are receiving poor medications, poor diethylpyram mixed with food. So using acamprosate here is challenging actually. I want to ask if you have given any patient temperature covertly without
No, no, not
telling
at all.
him after
No,
crushing it, mixing it in the food.
no,
What's
no.
your
That is
experience?
no, no, no. We absolutely avoid this because that is how things are. Because most of the so-called Bengali powers are giving
Yeah,
disulfiram or incompressate in powder form to patients, which is not never the right answer. And as even as per MH 17, we should not be
exactly.
doing
Yes.
that. And we were absolutely not doing that. We were always outrightly clear that if you are taking it as your choice and not taking your choice, we're not going to be mixing and giving. That maybe is something which is maybe done more in psychotic disorders, other respective disorders, but not so much in addiction because it becomes more difficult.
That's a challenge. That's a challenge in Chhattisgarh
Hmm.
where I practice. 90% of patients are receiving covert disulfiram. And 10% of patients are actually coming to the clinic. So that's a big challenge.
Yeah, actually, because if you see treatment gap is a lot, it's as much as 80 to 86%, I think, in one of the surveys for alcohol use disorder. So in this treatment gap, many of them are actually receiving treatment from quacks or Bengali
Babas.
Babas. Yeah, that happens a lot. Again, can't say good, bad, or something. Let's see if there are any other questions. I think there are no other
Risperidone
questions
drops अच्छा हलता है इसमें फिर ऐसे.
overtly.
For the alcohol, what he was asking, no,
Hmm.
then rather than
Hmm.
giving Acamprosate,
Hmm. Hmm. Hmm.
safer option is risperidone drops.
Yeah. Very practical tips, sir. Very real world tip.
And नहीं, practically the reason is I am not giving for alcohol. वो एग्रेशन के लिए आया था ना, बीबी को बहुत मार रहा था. So
Hmm.
वुमन राइट्स वाले ने मुझे रिक्वेस्ट किया तो रिस्पेरिडोन ड्रॉप्स मैंने सजेस्ट किया, खाली दिया नहीं मैंने.
Hmm.
I
Hmm.
just suggested risperidone drops.
Any of my respective panelists want to add any other point because we don't have any other questions that it seems at this point of time. So then, if Mr. Rahul, if we can end it now.
Yes.
Yes, sir. Yes, sir. We covered that all the questions, sir.
And
We can
thank
we
you.
can end it. Thank
Thank
you,
you,
sir.
everyone. Thanks. I'm very thankful to my respective panelists for their wonderful opinions and additions. Thank you, everyone. So we'll be getting back to you soon with baclofen as the next topic, possibly. And please do
Yes,
give your
sir.
feedback. Use that. This video will be uploaded soon. I'll also share the company. We also share the links. It would be very useful. Please do share your feedback. It helps us a lot in refining how we teach and what topics are chosen, what facts are highlighted, what are not highlighted. So please, I would request everybody. And it's an anonymous feedback. You can give good feedback. You can give more constructive feedback also.
Thank you. Thank you, Dr. Siddharth, and our expert panels, Dr. Sagar Karya, Dr. Pratik Rajput, Dr. Mahesh Gigal, ma'am, Dr. Shruti ma'am. for your time and enlightening that the entire delegates on the Acamprosate. Thank you very much.
Thank you,
Thank
everyone.
you. Thank you very much.
Good
Thank
evening.
you,
Good
everyone.
Great
night, everyone.
session.
Yes.
Good night.
Yeah, good night.
Good night.
Bye.